In the last part of this chapter, we're going to be talking about relatively specific diseases of the immune system. And like many diseases, they could be primary or you're born with them, which are genetic or inheritable. Use whatever term you want, or you can acquire them. So if you want to regard the primary immunodeficiencies as genetic and the secondary immunodeficiencies as acquired, then you're thinking correctly. Usually I highlight the important letters in a phrase which I think is important, and for some reason you'll notice I highlighted the I, the D, and the S in the phrase immunodeficiencies, and when we got to the secondary or acquired immunodeficiency, I put a big A in there. So if you add up all these red letters, you got A, I, D, S, and I think you've probably heard of that disease before. But let's start out by talking about the concept of the primary or inheritable or genetic immunodeficiencies. There's a bunch of them. I think you should recognize the names easily. If you hear somebody has a Bruton or a common variable or IgA or hyper IgM, or if you remember we talked about DiGeorge disease or syndrome as well, or if you hear of a SCID, which is severe combined immunodeficiency, or a Wiskott-Aldrich syndrome, or various complement deficiencies, know that they all fall into the category of diseases in which there are genetic defects, inheritable, which result in failure of differentiation of cells in the immune system. And because they occur early in life, they primarily involve children, and they have a wide variety of cellular and or humoral immunity problems ranging from not severe to absolutely fatal. And rather than going through each disease, I think I would like to point out the features of all of them. If you remember your cell differentiation tree, if you take the immune cell, the lymphocyte, and of course, if it's a B lymphocyte, it's going to be in this shaded area in the bone marrow, or bursa, if you will, BBB. And if you remember, the higher up you are in the tree, the more important the cell is, because the cell gives rise to cells of lower generations. And the further down in the tree you are, where a defect might occur, probably generally the less severe the disease. But if a disease occurs of the mother of all B lymphocytes, let's say, it's going to be a severe deficiency, and it could literally affect, all the B cells and all the antibodies. Or if it's a cell that also gives rise to a T cell, it's going to be a serious and probably fatal disease. So here's your theoretical pluripotent stem cell. Here you have another direct descendant of it, which can give a rise either to the T cell line or the B cell line. Well, let's say there was an enzyme called ADA, or adenosine deaminase, which would enable that cell to differentiate in either the B or the T direction. Let's say there was a genetic deficiency of that enzyme. Well, now you're understanding the basic process. Let's say that your pro-T cell could not differentiate into an immature T cell because of another genetic problem involving a protein, which was a cytokine receptor gamma chain. Excuse me. Well, now you're talking about a severe defect, or it would certainly be more severe than something that happened to the progeny of that cell. For example, if that immature T cell could not differentiate into CD8 and CD4 cells, and the defect was at that level, we're talking about DiGeorge syndrome. If we're talking about a defect in which it could differentiate into CD8 cells, but not CD4, then we're talking about another theoretical and probably less severe deficiency than a DeGeorge syndrome. On the B side of the tree, let's say we had a defect which involved the lack of differentiation from a pre-B cell into an immature B cell. If that was the case, the defect would be at this level, and that is X-linked A-gamma globulinemia. This is Bruton. If, for example, you then did have your immature B cells, but you couldn't differentiate into a specific IgE, IgA cell, that's the defect would then be at that level. If you had a defect in which you could make IgM, but not the other IgAs by virtue of not being able to differentiate into the specific G, A, or E lymphocytes, you would then have a hyper IgM syndrome. And that's the general concept for all of the primary genetic immune diseases. And remember, rather than going into all of the diseases specifically, I think this was the best way to handle it because you're not going to remember all the details about each one anyway. If you can visualize or understand that if you have primarily a T cell defect, all immune problems are possible, but most likely the patients are going to be affected by viral type illnesses. So a primary T cell defect is more likely to cause a viral illness, where a B cell defect anything is possible, but it's more likely to result in a bacterial, and specifically a strep, a staph, or a H. haemophilus type of problem. Similarly, a granulocyte defect would manifest itself similar to a B cell defect, but specifically, you're more likely to encounter a staph or a pseudomonas type of infection. So when you see patients that have various types of disorders, and you look at the expression of their disease, you can pretty much know whether it's going to be a T cell, a B cell, a granulocyte. And in the case of a complement disorder, for example, that would be similar to a granulocyte defect, but for some reason, Neisseria infections are very, very abundant with genetic complement disorders. Okay, let's open up the door now to another type of immunodeficiency disease, or IDS, which is acquired, and hence the acronym AIDS. And that's what we'll deal with in the next clip, and I thank you very much.